Welcome to the deep dive. If you are a medical student, a resident, or any young professional specializing in the head and neck, this deep dive is absolutely built for you. We've gone through and pulled what we think are the most high-stakes, actionable, clinical, and surgical principles from the entire spectrum of ENT.
And the goal today is really efficient synthesis. We're treating this like an intense, focused study session.
Right.
We're just extracting the critical diagnostic markers, the core management strategies, and the pathophysiology behind it all. You should walk away with clear, practical knowledge that goes beyond the textbook and right into the clinic.
Absolutely. Ready for rounds or the exam room. So let's start with, I think, the highest stakes topic in head and neck, malignancy.
Right.
Our sources really highlight squamous cell carcinoma, SCC, particularly of the tonsil. It's an aggressive pathology. Before we get to prognosis, what are the primary risk factors we need to be counseling patients on?
Well, you can never forget the classics. Smoking and heavy alcohol use are still major players. But the modern clinical landscape means we have to recognize two other factors that have, frankly, just reshaped how we manage this.
Which are?
HPV, the human papillomavirus, and then in certain global demographics, betel nut chewing.
And that introduction of HPV, I mean, it completely changes the conversation about outlook, doesn't it?
It really does.
It moves the disease from being almost universally grim to one where we can actually offer significant hope.
Yes, and that distinction is paramount. The sources are so clear on this. HPV-associated SCC patients have a significantly improved overall survival.
What are the numbers on that?
Statistically, we're looking at a 58% reduction in the risk of death compared to non-HPV tumors. It's huge. And these patients, they tend to be younger, often non-smokers, and interestingly, they might present with a smaller primary tumor, so a low T stage, but with much more advanced nodal disease, a high end stage.
That is a clinically crucial distinction that drives everything from staging to treatment choices. Okay, let's pivot from that long-term risk to, immediate life threats. We have to talk about rapidly progressing infections. Specifically, the terrifying presentation of Ludwig's angina.
This is one of those scenarios where speed is everything. The airway can compromise so rapidly.
So what is it exactly?
It's a cellulitis, a very aggressive one involving the floor of the mouth and the neck. And the sources tell us that in 90% of cases, it's odontogenic in origin.
So it often starts simply as a tooth infection.
Precisely. Usually it's an infection in the second or third molars that penetrates the mylohyoid ridge, and that lets it spread like wildfire into the submandibular and sublingual spaces.
And the key sign, the life-threatening one, is the tongue.
It's the hallmark sign: progressive swelling, elevation, and posterior displacement of the tongue. That is what leads to the acute obstruction.
So management starts and ends with securing that airway. What comes right after that?
Airway security is the absolute foundation, non-negotiable. After that, aggressive 5E antibiotics are essential, usually a combination like penicillin, clindamycin, or metronidazole.
And imaging.
You need a contrast CT. It's essential to define the extent and, critically, to confirm if an abscess has formed.
Which happens often.
In about 2/3 of cases, yeah. And if there's an abscess, it needs surgical drainage once the patient is stable.
And sometimes, the airway is so bad you can't intubate. That leads us to a surgical airway. So compared to long-term intubation, what are the key advantages of a tracheostomy?
A tracheostomy, especially an early one, say within the first 2 weeks, offers several major benefits. First, it significantly reduces the risk of tracheal trauma and the stenosis that can follow.
Right, from the tube pressing on the mucosa.
Exactly. It also reduces respiratory dead space, which makes it much easier to wean the patient off the ventilator. And of course, once the patient is awake, it allows for speech and safe oral feeding.
But those benefits are balanced against some pretty severe risks.
Oh, absolutely. The list includes things like tracheal necrosis, stenosis, dysphagia, so difficulty swallowing, and the tube itself can dislodge.
And the big one.
The one we all fear is the tracheoarterial fistula, or TOF, a true surgical emergency where there's erosion into the innominate artery.
Okay, let's move down the neck a bit and talk salivary glands. Patient presents with a painless lump near the angle of the jaw. What's at the top of our differential?
In the parotid gland, the odds are strongly in your favor. About 80% of these lumps are benign.
So what's number one?
Number one is a pleomorphic salivary adenoma, or PSA. To confirm it, FNA cytology fine needle aspiration is the go-to tool. It's got an accuracy rate over 96%.
So if we proceed to a periodectomy for that PSA, The facial nerve is obviously the critical structure, but beyond that, what specific items have to be in the consent?
Mandatory consent points, right. Of course, you have to mention the risk of temporary or permanent facial nerve injury. That's a given.
Mm-hmm.
But you also must counsel on numbness to the ear lobule, the risk of recurrence, and you have to remember that PSAs have a small but real, maybe 2 to 10% chance of malignant transformation if you just observe them for years.
And the sweating.
And Frey syndrome, yes, that unfortunate gustatory sweating that happens when they eat.
Shifting to another salivary issue, Stones. The patient has pain and swelling around mealtimes, especially in the submandibular duct. During surgery to remove that gland, which 3 nerves are we most worried about?
3 major nerves at risk: the marginal mandibular branch of the facial nerve, the hypoglossal nerve, and the lingual nerve.
And there's a specific maneuver to protect the marginal mandibular, isn't there?
There is, and it's a key detail. It's called the Hayes-Martin maneuver. You ligate the inferior part of the posterior facial vein, and then you reflect it superiorly.
And that protects the nerve.
It does, because the nerve lies just superficial to that vein and deep to the platysma. It's a really elegant way to keep it safe.
That makes the anatomy crystal clear. Okay, let's move upstream to the voice. Laryngology. A chronic smoker comes in with worsening dysphonia. What's the most common site for a laryngeal cancer?
The glottis, the true vocal cords, that accounts for about 50% of laryngeal cancer.
None of the others.
After that, it's the supraglottis at 40%, and thankfully, the subglottis is least common at around 10%.
And glottic tumors are often caught early, I imagine.
They are, because they affect the voice so early on.
Okay, for everyone listening who's studying for exams, let's nail down the T classification for glottic carcinoma.
Yes, this is something you just have to internalize. So T1 is the best prognosis. The tumor is limited to the vocal cord or cords, and this is key mobility is normal.
And T1A versus T1B.
T1A is just one cord involved. T1B involves both cords.
So once mobility is affected, we're moving up the scale.
Exactly. T2 means the tumor has extended to the supraglottis or subglottis, and/or vocal cord mobility is impaired. Not fixed, but impaired.
And the jump to T3 and T4, what defines that?
T3 is vocal cord fixation. It's not moving. Or there's invasion into the paraglottic space. T4 is when it's breaking out of the larynx.
And T4A and T4B.
T4A means it's invading through the thyroid cartilage or into other structures like the trachea. The most advanced, T4B, means it's invading the prevertebral space or encasing the carotid artery. It's unresectable at that point.
That's an invaluable progression to understand. Now, to assess that function, we use stroboscopy. Explain how that works. How does it capture such a rapid vibration?
Well, the vocal folds vibrate hundreds of times per second. It's way too fast for the naked eye to see the mucosal wave.
Right.
So stroboscopy uses a flashing light, a strobe, that flashes at a rate just slightly slower than the vocal fold's fundamental frequency. It's an optical illusion, basically.
It makes the motion look like it's in slow motion.
Exactly. It makes the rapid, continuous motion appear slowed down or even frozen, which lets us see any abnormalities in the wave.
And what key parameters are you looking for when you do one?
We're assessing 6 essential features: the degree of glottic closure, the symmetry between the two cords, the periodicity or regularity of the movement, the amplitude of the mucosal wave, and finally, just the overall quality of the waveform.
Let's move upstairs now to otology and neurotology. Dizziness. That's one of the toughest complaints. How do we start to differentiate central versus peripheral vertigo in that acutely unsteady patient?
Well, for quantifying the peripheral function, caloric testing is still critical. We use tools like Junkie's formula to calculate asymmetry. You might find, say, a 58% unilateral weakness in the right ear, which confirms a peripheral deficit.
I've also heard of Brunn's nystagmus in these cases. What does that specifically tell us?
Brunn's nystagmus is a really interesting sign. It's highly suggestive of a large cerebellopontine angle lesion, so a large CPA tumor, most often a vestibular schwannoma.
And what does it look like?
It has 2 components. You get a sawtooth nystagmus from the peripheral vestibular loss, but that's combined with a nonlinear gaze-evoked nystagmus from compression of the cerebellum.
So it's a critical marker for a big central tumor.
Yeah.
But for the acute bedside assessment, everyone talks about the HNS mnemonic, right?
Correct. HESS stands for head impulse, nystagmus, and skew deviation. Now, if a patient has acute vertigo from a peripheral cause, like vestibular neuronitis, they must have a positive head impulse test to the affected side.
Meaning you see that corrective saccade.
You see the corrective saccade, the vestibulo-ocular reflex is impaired. Now, if the patient has severe vertigo and vomiting, and their head impulse test is negative, no corrective saccade, that is highly, highly worrisome for a central stroke.
Sticking with vestibular schwannoma, or VS, what findings might make you suspicious for one, even if the patient's hearing thresholds aren't that bad?
A few red flags on the audiology report. Look for a low word recognition score that's out of proportion to the pure tone loss, or absent cross-stapedial reflexes. The next step is usually an ABR auditory brainstem evoked potential.
And what would that show?
If it shows absent waveforms on the affected side, that's very strong support for AVS diagnosis.
But the ABR isn't perfect, especially for smaller tumors.
Not at all. It's a major limitation. The ABR sensitivity really drops for lesions under 1 centimeter. And if the patient already has severe hearing loss, say over 70 dB, the ABR might be abnormal anyway, which makes it unreliable.
Let's nail down another very specific diagnosis: superior semicircular canal dehiscence, or SCD. What's the classic clinical triad?
The presentation is truly unique. It's a third window phenomenon. So patients complain of autophony, hearing their own eye movements or footsteps resonating in their ear, or dizziness with loud sounds, which is Tullio's phenomenon.
And on the audiogram?
The triad is distinctive. You see a low-frequency conductive hearing loss, preserved stapedial reflexes despite that conductive loss, and often hypersensitive bone conduction thresholds, sometimes as low as -10 dB.
That specificity is really helpful. Okay, let's wrap up with some applied knowledge for the OR and ICU. Reconstruction. Tell us about the 3 phases of skin graft healing.
Okay, so the graft has to survive. The first phase, up to 48 hours, is called imbibition. The graft is just surviving purely by diffusion of plasma nutrients from the bed.
And after that, what happens when the blood supply starts to connect?
That's the second phase, an osculation. That lasts for about a week. It's where the capillaries from the bed start to align and link up with the capillaries in the graft.
And the final phase.
Finally, you get revascularization, where new functional blood vessels form and fully integrate the graft.
And while we're on surgical technique, let's quickly differentiate the 3 main suture needle types.
Sure. They're defined by their cross-section. You have the conventional cutting needle, where the third cutting edge is on the inner concave curve, great for tough tissue like skin.
Okay.
Then there's the reverse cutting needle. It's stronger, and it places that third cutting edge on the outer convex curve. This is better for minimizing tissue cutout.
And the last one?
That's the taper point needle. It's round. It pierces by stretching tissue, not cutting it, so it's ideal for delicate structures like dura or peritoneum, where you want to minimize tearing.
Excellent. Let's finish with critical care safety. Local anesthetic toxicity. What are the warning signs we need to watch for before the patient collapses?
The toxicity often starts with CNS effects. So clinically, you're looking for early signs like tinnitus, a metallic taste, tingling around the mouth, perioral numbness, and then motor twitching.
And if you miss those?
It progresses rapidly to grand mal seizures, then CNS depression, and finally the most dangerous stage: cardiovascular effects like severe hypotension and cardiac arrest.
Last high-yield point: pulse oximetry. We use it constantly. Remind us how it works, and more importantly, when does it lie to us?
So it's based on spectrophotometry. Oxy and deoxyhemoglobin absorb different wavelengths of light, red versus infrared. The oximeter just measures the ratio to calculate saturation.
And when does it fail?
It fails when that ratio gets thrown off, either because of poor peripheral perfusion like in shock or hypothermia, or, and this is the classic one, in carbon monoxide poisoning.
Why is CO poisoning such a notorious failure point?
Because carbon monoxide binds to hemoglobin about 250 times stronger than oxygen does, creating carboxyhemoglobin.
And the oximeter can't tell the difference.
It can't. Carboxyhemoglobin is bright red, so the pulse oximeter reads it as being fully saturated with oxygen. It gives you a falsely high reading, which masks profound, life-threatening tissue hypoxia. It's a classic clinical pitfall.
That is the perfect note to end on. A reminder connecting basic science right back to patient safety. We have covered a huge amount of ground today.
We really have.
From staging laryngeal cancer to the physics of skin grafts and the critical difference between central and peripheral vertigo.
It really just underscores the holistic knowledge you need in ENT. And using these case studies, the goal is always to make the abstract concept practical and applicable.
To reinforce that, here is your review exercise for this deep dive. Imagine you have a patient who presents with dizziness to loud sounds, Tullio's phenomenon, and they also report hearing their own footsteps resonating in their ear. Based on our discussion, name the likely diagnosis and list 2 key findings you would look for on their audiogram to confirm this.
And finally, let's leave you with a provocative thought, building on laryngeal dysplasia. We noted the overall malignant transformation risk is around 14%. Now, while many centers still manage mild to moderate dysplasia conservatively, we are seeing a rise in active endoscopic laser management.
Right.
So the question is, how might this evolving surgical trend influence our long-term follow-up protocols and surveillance frequency for these high-risk patients?
A challenging but essential question for the future. Thank you for joining us for this intense deep dive. We'll see you next time.